Perfect. Thank you all so much for joining for our July North Country Telehealth Partnership Telehealth Learning Collaborative. My name is Nancy Del Mastro. I'm the Telehealth Project Manager at Adirondack Health Institute, and I manage the North Country Telehealth Partnership alongside my partners at Fort Drum Regional Health Planning Organization. Today we have a quick agenda. We're going to hear some state agency updates just from DOH today, and I'll be reading those off on behalf of Kendra. Then I'll turn it over to Tony Jamrazi over at CMS to provide some Center for Medicare and Medicaid updates. And then we'll be hearing from Jennifer Newberry and the team at Health Recovery Solutions on remote patient monitoring. We'll end the call with a few updates on behalf of the partnership. So just getting started, I want to make sure I'm not missing any other panelists in our attendee list quickly. I think we are all set. Great. So I received some updates from Kendra Muckle over at the Department of Health. She let me know to mention that the telehealth policy updates at DOH are that the program is wrapping up review of public comments to the telehealth regulations, and many of them are favorable, which is great to hear. Emergency regs continue to be in place to bridge any gaps, and the comprehensive post-pandemic policies are currently being drafted. Telehealth work groups, surveys, and provider feedback continue to inform the telehealth policies for DOH and the Medicaid program. Last month, the telehealth consumer survey that was blasted out on behalf of our state agencies was sent out. There are new flyers that have been created and are available to post in your offices, and Kendra asks that we all share that information widely so we can get as much information on telehealth from the consumer aspect as possible. It is important to note that the surveys are open to all, not just Medicaid members. And Kendra did let us know that this would have been her last call in her position. She's moving into another position at DOH. So we will see some new names on behalf of DOH at our further learning collaboratives in the future. So thank you to Kendra. She's not on right now, but on behalf of the partnership and our partners, thank you for always providing such great comprehensive updates for us. I do see Tony on. Tony, are you able to provide any CMS updates?
Can you hear me?
Yes, I can.
Yes, okay. Yeah, thanks. Good afternoon. The proposed rules for the calendar year 2023 Medicare payments are starting to come, appear on July 7th, and it's still setting in the for inspections section of the Federal Register. The proposed rule for the Medicare physician fee schedule came out. That's up for comment through September 6th. And then just last Friday in the afternoon, the proposed rule for the hospital outpatient physician fee schedule, hospital outpatients prospective payment system. That rule appeared, and it's also sitting in the for inspection section of the Federal Register. You remember the development of telehealth coverage under Medicare. The original law contained a section 1834M, which with a few wrinkles limited telehealth to patients in a rural area in an originating site that's a health facility like a hospital outpatient department or a health center. And it required that the telehealth service be audiovisual. When the pandemic came along in the beginning of 2020, basically those requirements were all waived. And the originating site could be anywhere geographically. The patient could be anywhere, including in their home. And for certain services, audio only contact between the practitioner and the patient would be covered. Um, there was a provision in the Consolidated Appropriations Act of 2021 that basically made those rules permanent for mental health services. And there was no geographic requirement. The patient could be in their home, and with certain conditions, audio-only service could be covered. The one wrinkle there was that before any telehealth service could be paid, the patient had to be seen in person by that practitioner within 6 months previous. And after a period of 12 months, in-person service should occur every 12 months, and also with certain exceptions. So the next step was there was a Consolidated Appropriations Act of 2022, which basically said that when the payment public health emergency ends, the waiver of the geographic requirement, the waiver of the site of service requirement, and the audio only services in certain cases would continue for 151 days. Okay, so that's the background. Um, Basically, the Medicare physician fee schedule rule, the list of telehealth services uh, basically remains unchanged. But certain services are marked for elimination 152 days after the um, public health emergency ends. And basically the provisions of that Consolidated Appropriations Act of 2022 are spelled out. Um, the geographic requirements don't apply for 151 days due to the site of service requirements, and in certain situations, audio only services can be covered for 151 days. And for mental health services, the requirement for an inpatient visit is delayed for 151 days after the pandemic ends. Um, After the pandemic ends, there's going to be a change in coding. Right now, what the under the pandemic rules, uh, you put the place of, there's a place of service O2, which is recognized as uh, a telehealth service provided in a high-end facility, and that's going to continue to be used. But right now, the main instruction is to report the place of service where it would ordinarily be provided in your office, maybe, or in a hospital outpatient department, and identify it as a telehealth service by using a modifier 95. And there's also for mental health services a a modifier for audio only services. I forget exactly what it is. I think it's GW or something like this. But after the pandemic ends, 151 days after the pandemic ends, I should say, uh, uh, there'll be telehealth services will be identified by two place of service codes, 02 and 010, where the patient is in their home. Okay. And for audio only services, there'll be a modifier 95, which I believe was the modifier for that CPT contained. And let's see what else. Okay, there's a request for information on uh, certain services required direct physician supervision, which means that when they were provided, the doctor had to be there, or like certain services can be supervised by a physician assistant, but the practitioner had to be there in person was the old rule under the pandemic. And now I guess until, 151 days after the pandemic, the rule can be satisfied if the practitioner is available, audiovisual means. And basically what they're asking, 151 days after the pandemic, this would go away. And they're asking if for particular services, um, a virtual direct supervision uh, could still be allowed. So, as I say, the rule is available for comment until September 6th. The outpatient physician, or rather outpatient prospective payment system rule also contains a section regarding remote mental health services provided by a hospital. The wrinkle here goes back to that section 1834M again, which lists or, by reference, the types of providers that can provide telehealth services, and hospitals are not on that list. So during the pandemic, hospitals were allowed to bill and be paid for mental health services provided by their staff, uh, where, like no other physician service was being paid. And that uh, uh, they're proposing to make that permanent starting in calendar year 2022. And basically the staff, there's going to be special codes for it, and it would be payable as an outpatient prospective payment system service. Uh, the staff doing it would have to be in the hospital, and that prior 6-month personal visit and the in-person service every 12 months that are in the Consolidated Appropriations Act 2021. Those would also apply, and audio-only services could be provided under certain conditions. So basically what they did was, they're not listed as a telehealth provider, but the mental health service is a covered telehealth service. And there's a couple of things about related to rural health centers, federally qualified health centers. Um, for one thing, everybody, you're available now to be paid separately for general care management, behavioral health integration, principal care management. Now they're proposing a new, patient care uh, management for chronic care management and for general behavioral health integration. So these would be new services, and the rule contains, uh, you know, again, it's this rule is uh, out for comment until September 6th, and they're asking for, basically information about defining these services and how to price them. And yes, for mental health, for rural health centers and federally qualified health centers, the delay in providing the in-person mental health visit is delayed for 151 days after the pandemic ends. The site of service geographic waivers, and they're also still in effect until 151 days after the pandemic ends, including the audio-only services. So that's what I have. Do you have any questions? Any questions?
Thanks so much, Tony. I don't see anything in the chat or Q&A boxes just yet, but I encourage all of our participants to
Okay.
submit any
Now,
questions you may
yeah.
have, and we could also follow up via email.
Now I have the sections from these rules carved out. You know, if anyone wants the section to take a look at it,
Yeah, if
I
you
can
could send
supply
those to
this.
me via email, I'll make sure to add those to the meeting notes
Okay.
so everyone
All
can
right. Okay.
reference them. Thank you so
All right.
much.
Okay. Thank you.
Awesome. And so that's all we have for our state and federal updates. I'll make sure to have all of those in the meeting notes that I send out after the call, either today or tomorrow morning. And with that, I want to turn it over to Jennifer Newberry and Jenna Kowalski, who are going to be presenting on remote patient monitoring challenges, cost saving, the telehealth coordinator model, and success stories.
Hi, good afternoon. I'm Jennifer Newberry, and I kind of just wanted to go over some of our challenges and how we were able to overcome a lot of them with the use of a dedicated telehealth coordinator. When we first rolled out our remote patient monitoring program, we had one in place, but we replaced it with a better program through a grant from Adirondack Medical Center, and they provided us with 45 telehealth units. Each unit had a blood pressure cuff, a scale, a pulse oximeter, and a thermometer. We also could have had a blood glucose monitor, and we chose not to take any of those. But the use of the computers with our aging population and the tablets with the remote patient monitoring system, the seniors that we visited seemed fearful and overwhelmed by the use of the equipment. And with the addition of our telehealth coordinator, who had some dedicated time to train the users, the majority of our users are now over 80 years old, and a third of them are over 90 years old. The telehealth coordinator initially spends about an hour and a half with each user, teaching them about the equipment and how to troubleshoot it. And when the data comes in real time to a computer at our agency and also on our cell phones to indicate when there's a problem or they're not using them. And when that happens, the telehealth coordinator will reach out and speak to the user and try to identify why they're not using it. Sometimes it's a battery failure, lost internet connection, or the equipment's not connecting for some reason. And then the telehealth coordinator would visit the user if necessary to troubleshoot the issues. So this kind of reassured them, and it also improved their competency with the use of the telehealth equipment. One of the other challenges that we ran into was the lack of available internet or cell tower service, which didn't allow the telehealth equipment to be utilized as intended in all areas of our county, Essex County. But the workaround was we continued to utilize the telehealth equipment in the homes, and we trained the user what parameters they would call our agency or their doctor, or survey questions that they needed to notify us of. So like if it was a weight issue, they would call us if they gained 3 pounds in a day, and that kind of thing. The nurses weren't really, they really didn't have an extra hour of time to train users and troubleshoot the equipment. So it encouraged them to order it more readily, because they weren't going to also be responsible for all the workload that went with placing a unit and training the user. So all they had to do was contact the physician and write the parameters for notification to the physician. So that was helpful. We estimated a total cost savings initially of $200,000, but it was it was beyond that amount. The cost savings was based on a reduction of hospital admissions and also a reduction in the amount of nursing visits. Depending on where you live, an average cost of a hospitalization at the time of this report was $42,000. And then we used hospitalization calculator that was provided by Health Recovery Solutions, which was pretty helpful. And we did reduce hospitalizations of all telehealth users by 60% consistently for the last 5 years since we've had this equipment. Some patients receiving the telehealth equipment had really high hospitalization rates the 2 months prior to placing the equipment, or ER visits. We had one patient that had 30 ambulance calls in 30 days prior to using the telehealth equipment. And after we placed the telehealth equipment, she had 2 ER visits in the next year. So it definitely saved a lot of ER visits for that one individual user. So we estimated with our first year of use that we had prevented at least 5 hospital admissions, which totaled $210,000. And about 15% of our home health patients were using telehealth overall the past year. The community patients, some of the patients that utilize telehealth or remote patient monitoring after they were discharged from home care wanted to continue to use the equipment, and we did leave that equipment in the home. We did not charge them for it. The equipment was given to us as a grant, and we felt like we could afford to do that. And the cost to us was basically the telehealth coordinator's time. Our telehealth coordinator spends about 3 or 4 hours a day dedicated just to the telehealth equipment. And that position is at 20 hours a week. We estimated that we've placed over 200 units. We place about 10 units a quarter since our telehealth program began 5 years ago. And we looked at the hospitalizations over the last 5 years, and we determined that the hospitalization rates for telehealth users was much lower than the rest of our patient population. Since the start of telehealth in 2017, we had an average annual admission of 445 patients, and the skilled nursing for all these patients declined from almost 4,000 visits a year to 3,000 visits a year, and which is cost savings of about $200,000, an additional $200,000 a year. The other example that we have of another cost savings was we have patients who are TB patients, and they used to have direct observation therapy where the nurse would have to go to the home every day and watch them take their TB medication. And we were able to do that remotely using this remote patient monitoring tablet, and we could watch them through a video call. And so we estimated a cost savings of $41,000 per patient for that are on direct observation therapy, saving the nursing visits and the drive time. We determined that the telehealth coordinator position was sustainable for our patient population at a part-time benefited position at 20 hours a week. The majority of our patients are Medicare, which does not directly reimburse, but some of the other payers do reimburse for remote patient monitoring and telehealth visits. Our speech therapy person lives pretty far away, so all of our speech therapy is virtual. It's been very successful, and otherwise patients who had a stroke or swallowing or speaking difficulties would not have any speech therapy under home care because there's not any home care in our county that can provide speech therapy on site. And we are the only ones that provide it remotely. So, so that's been beneficial to our patients. We also monitor patient compliance with the equipment. They don't always have 100% compliance with checking their vital signs or answering the survey questions every day. But, and there's several reasons why they're non-compliant. But when they don't maintain compliance, the telehealth coordinator will contact them and identify the reasons. And, you know, for example, one patient, the batteries ran out, and so, you know, we usually teach them how to change that out, and we give them extra batteries and things like that. So that does help improve their compliance when the coordinator reaches out to identify the reason for that. Patients and the customers seem more engaged in their healthcare when they need to contact the agency. For example, if they have anxiety that's increased or their vital signs are not within the parameters. We also reach out to them because we get an alert on our phone, and they seem to seek healthcare earlier and make adjustments to their medications. They do some MD virtual visits and or real visits, and our patient satisfaction rate is 5 out of 5 stars and has been for the last 5 years. So we feel like overall the care that they get, they are very satisfied with. Some of the examples that we are telehealth users, we had a patient on palliative care who wanted to pass away at home, and she had telehealth equipment in the home. And so when the patient wasn't doing well, the family would put the pulse ox on her finger, and then it would alert our phone that her pulse, that her oxygen level was low, and the nurse would call the home and reassure the family we were just a phone call away. And they asked the family if they wanted to send this patient to the hospital, and they said no. And so every time they felt like they needed a little support, they would put the pulse ox back on the person's finger, and we'd call them, and she did get to pass away at home. And that support that we could provide in real time made the difference for the family. So that was a good example of how we used our telehealth. And I talked to you about the patient that went to the ER 30 times in 30 days. And so we reached out to our EMS, and we identify patients that are frequent users of the EMS system, and we try to troubleshoot using the telehealth equipment. We also had a patient that was fairly overweight and was trying to get their weight down. And so they used the scale, and they knew we were watching, so they were compliant with using the scale every day. And they were able to lose almost 100 pounds, and this person couldn't afford health insurance nor their end meds. So they bought the meds, but they didn't have any health insurance. And by the weight reduction, that person was able to come off all their meds except for one. They had 6 different meds, and then was able to purchase health insurance with the cost savings from all the meds they were buying. So we've had some pretty good success stories overall with our remote patient monitoring and the telehealth equipment. So I don't know if anybody has any questions for me before I turn it over to Jenna, and she's going to give a little more information about the uses of the equipment.
Thanks, Jen. I don't see anything in the chat or Q&A boxes right now. Again, I encourage all of our participants to ask any questions to Jen, and, you know, of course, her awesome experiences in Essex County Home Health. But we'll circle back on the chat and Q&A after Jenna talks about HRS specifically.
Great. All right. Well, thank you, everybody. Thanks for having us. My name is Jenna Kowalski. I'm the Vice President of Clinical Innovation and a nurse at Health Recovery Solutions. We are a nationwide remote patient monitoring company. We've been around for 10 years, one of the longest running remote patient monitoring groups around. And I have Sarah Alpart with me. She is one of our clinical services interns, and she's going to help me present today a little bit about remote patient monitoring, a little bit about the products that are offered out there for remote patient monitoring. This may be repetitive too, so we won't spend a whole lot of time on it. But what I'd really like to talk about is, exactly what Jennifer profiled so well in her fantastic program, is why it's useful in the healthcare space and in the ecosystem today, and not just useful in home health, which is where Jennifer's using it, but useful in all different use cases and all different areas of the healthcare system. And we can really talk a lot about how remote patient monitoring, specifically some of those guides and playbooks for those different use cases that we can offer for you if you are interested in that. So just wanted to spend a little time there as well. So I will kind of turn it over to Sarah to talk a little bit through what remote patient monitoring is in very general format, and then she'll turn it back over to me and we'll talk a little bit about the products and the use case. So Sarah, take it away. I hope you can, I know you had trouble logging in, so hopefully you're good to go here.
I think I am officially off mute, and obviously I'm Sarah. I'm a clinical services intern with HRS. So if you'll just skip to slide number 2, just a quick recap. I know most of you are probably familiar with the question of what is remote patient monitoring. But it is a general collection of physiologic data. It's digitally stored and transmitted from member to clinician or provider for interpretation and then intervention. So HRS provides remote patient monitoring and then in turn can help to address some common healthcare issues that we see. Remote patient monitoring does increase visibility into patients' care outside of just the traditional in-person visit to the doctor's office. So some things that remote patient monitoring can include or may offer would be like virtual visits via secure Zoom, disease-specific custom surveys for your patients, patient biometric readings, quizzes that can measure your patient's education, camera capabilities for wound imaging or other imaging, and increased patient and provider touch points. And Jenna, I'll turn it back to you.
Yeah, that's great. Thanks, Sarah. All right, let's go on to some examples of products. These happen to be HRS's products, but again, in the remote patient monitoring industry, they're all quite similar to what you see out there. In this particular screen, you'll see in the top left, this is what we call our complete kit. This is for typically for more acute and very chronic illnesses coming out of the hospital. So we see this in a hospital at home. We see this in our care transitions programs, our chronic care management, our physician programs, home health specifically, and any acute care at home type situation. SNF at home, we do have a couple programs that are operating a SNF at home model with these types of kits as well. And this includes a tablet, which is Bluetooth enabled for the peripheral devices that you see here. It has Wi-Fi built in. There's no need for the patient to have their own wireless internet or pay for a data plan or any of that. It all comes packaged inside of that tablet. And then it's attached Bluetooth way through the scale, the blood pressure, the pulse ox, and then we also have in this picture the Echo Duo, which can produce lung and heart sounds in future state and EKG as well. And then also we offer some other Bluetooth peripherals such as glucometers and thermometers as well, just for some other examples. So that's that particular use case there. And right below it, you'll see this is our Patient Connect mobile app. This is an app that can be put onto a patient's phone. So this is where we call this sometimes a step-down approach or for a more directed approach. So if we're looking at high-risk maternity, postpartum, hypertension, or we're looking at uncontrolled hypertension in a specific population. Maybe it's in a younger population that has more ability with their mobile app. They love their smartphones, right? So we can drop our app into their phone and they can go ahead and use our Bluetooth peripheral devices to get that information, and that it acts exactly as the tablet above in the complete scenario. So all the functionality of our larger tablet is all built within the app as well. It's a lower cost, it's a lower touch, but it does require the patient to have wireless internet and of course the phone cellular. And then on the top right, we do see advantages to just using a tablet. So in this particular case, we see this quite frequently, just the tablet in behavioral health. We see it in hospice care situations. We see it for hospice care in caregiver roles. So where we're supporting the caregivers through the tablet and helping to decrease their burden during that time frame. We have the virtual capabilities within the tablet, and you can also get survey questions. You can have education loaded up into the tablet. We can have quizzes for the patients to answer, and then all that imaging is housed in the tablet as well. And then lastly, we do offer an IVR platform, which is population level outreach with automated calling. So it's not as popular for us right now, but it's something that we do offer. Alrighty, and so the question is, why should we use RPM in virtual care? I'm sure many of you in all your different roles have thought about this, or are actually using RPM, or have considered it. As you heard Jennifer describe her program, I think the one thing that comes in loud and clear is that RPM connects your patient. It connects your patient to a provider so that you can get timely intervention and get it very quickly, and you can intervene and get the patient to the right level of care at the right time. So Jennifer, I love your example of your patient who had called, unfortunately, went to the ED 30 times in 30 days, which is extreme. And then once you intervened, there was a direct link now to your patient, and you were able to make sure that each time they reached out, they got the right care at the right time. So it could have just meant a tweak to the medications. Instead of sending them directly to the ED on a Saturday night, it could have just been calling the doctor to get an extra dose of Lasix the next morning for that heart failure patient, for instance, or a nebulizer treatment for that asthmatic that afternoon. So there's a lot of ways to use this. It's really important that we can do this, have this connection to get that timely care. But that's where we see the main advantage, and we see readmissions decline drastically. We have over 320 partners across the country, and the largest, outcome here is the patient outcome for readmissions and decreased ED visits in all scenarios. You can't deny the fact that, hey, we're connecting you 7 days a week. We're going to affect your care in some way, shape, or form. So that really is the number one reason, I think, when you're looking at this. But there's so many other reasons to do it. It can be done across the continuum of care. So as we talked all those different use cases, we can connect a patient through RPM ultimately from birth to death, if we really want to. We can connect them throughout the journey, through the continuum of care, and we can go ahead and do that in all sorts of ways, in all sorts of touch points. So you saw with the product that you see there in the different peripherals, we can adjust that by case, by issue, by patient, and by population. And the data that's provided between RPM and then your virtual care, we can detect rising risk through those changes in biometric readings and survey answers over time. We can take a look with compliance and medications, medication management. And when you talk about medication management, I like to throw out the new Medicare codes for RTM. That's something that we can address here. We can address your pain scores and your pain management, your medication management, and we can look at therapy as well as respiratory things in here as well. We can start talking about RTM a little bit when we look at RPM. We look at compliance with their care plans. What are they doing? Are they being compliant every day? And to Jen's description earlier, if they're not compliant and they don't test for the day, Jennifer's coordinator reaches out to the patient and says, hey, Mrs. Smith, I see you didn't test today. What's going on? And she says, I was really tired. I didn't get to it today. And that's an opportunity for education. So we can really improve that. And then lastly, one of the big reasons here is great is you have patient engagement. So Jennifer gave a great example of patient satisfaction and engagement. We can do that through the use of RPM and virtual care by measuring their satisfaction surveys, their health survey answers, how many educational videos they have watched, did they answer any quiz questions, and then of course any contact directed through PDF education. So you can upload any PDF education that you might have for your health system into our tablet or smartphone, and you can direct your patient to that education, whether it's directing them to your, potentially your patient portal and educating them on how to log in, or connecting them to a payer if it's Aetna, and we say we want them to utilize their website to go ahead and take a look there. We can increase engagement there. And you can also ask survey questions to your patient frequently to see how they're satisfied with the program. Okay, and then just a little blurb on HRS. I didn't want to stay on this too much, but we take care of everything. So if you're going to think about a remote patient monitoring program and virtual care in your setting, we have a full suite of solutions for you, including clinical experts like myself and Sarah. We'll walk you through your clinical operation. We'll walk you through your measures of success and help you track your implementation and beyond. and work with you on how to develop that program. We also have 24/7 tech support located outside of New Jersey. If there's something wrong with the equipment and the patient is on the other end, they just click a button on their tablet or their phone, and then one of our tech support guys will come on and walk them through any of the issues. Client success specialists, they will walk you through your program every day. They'll be your point of contact. We also have reimbursement and grant specialists. So we have a VP of reimbursement who can walk you through revenue cycle, look at those CPT codes, help you with billing on the back end, and help you get reimbursed. And Jennifer, one thing I'd like to point out too is the fact that you are getting reimbursed from some of those commercial payers is fantastic. And they love that from a home care standpoint. Once you see results on those commercial payers, we'll love to get on board and start, paying you for those programs because you're seeing such a significant decrease in cost of care. And then we have a grant specialist also. I want to give her kudos. Shelly Davis is our grant subject matter expert, and she can help walk you through the grant process and help you kind of tweak that as well. And then we do offer full service logistics. We have what we call patient direct, where we ship the kit, the equipment directly to the patient if you'd like. And then we even virtually install it over the phone. So that's an option. And then we also do have a third-party vendor who can offer clinical monitoring. So we can have a nurse on the other end. If you're struggling with staffing issues and you want to list this product or program rather, we can have you hook you up and get you those nurses that can do that clinical monitoring as well. And then what I really also want to talk about is those use cases. So where do we see remote patient monitoring and virtual care in the community? So where is HRS seeing it? So these are really the four kind of tracks that we're seeing RPM being utilized. The first one is the inpatient use case. So in the hospital setting, we have developed playbooks or clinical guides that walk a potential customer through a specific use case and how we would think to use remote patient monitoring. So for instance, the emergency department diversion and triage, this is something that we came up with during COVID to help the hospital system look to get some of those patients that may not have been appropriate in the ED right out of the gate and get them out of the ED and maybe home with some connected services, but not going through the double doors and actually taking time from the staff and getting them in the hospital setting where they don't necessarily need to be. So sending them home with equipment, whether it was the mobile app, whether it was the full kit, and sending that patient home right in the ED, right back home with equipment so that you're connecting them to care and still treating them for care, but they're not going through and taking up time in your ED for more that you have need time for more acute cases. So this was specific to COVID, especially because the hospital system was so overwhelmed and the staffing was such an issue too at the time. So we do have playbooks that we can kind of describe how this works, but that really was the biggest use case at the time. And you can think this would be helpful in any case. It would be helpful in an event where you're having staffing issues in your ED or your hospital in general, where we can treat patients at the right level at the right time. And we can do that when they walk in the ED by having a plan to say, we're going to admit, the most acute patients, patient one, patient acuity level 1, they go through the double doors. Patient acuity level 2 and 3, they're going to go home and get home care services with equipment. And patient acuity level 4, they're going to get the mobile app, and we're going to touch base with them for 7 days to make sure they're okay and that they don't exacerbate. For instance, like a COVID patient may not be ready to go in and be admitted, but we just do want to keep an eye on them. So there's a lot of use cases for the equipment to keep your patients out of the ED, but also help with staffing up on the bed, up on the floors rather too. Early discharge, that's looking at patients who have been admitted, they're on the floor, they might be ready for discharge a day or two early to home care. So why not send them home and feel more comfortable discharging them a little early with all of this equipment and then more care. So sending them to Jennifer's team, they'll have the equipment, and then you'll have that direct connection to a provider. So if there are exacerbations, you can get those in timely and get them treated. And then lastly, one of the newer cases that we're seeing is what we're calling a virtual inpatient nurse program. So we have hospitals that are deploying our equipment, specifically the tablet in most cases, onto a med-surg floor into the patient rooms. And so each patient has a tablet and they're connected to a virtual nurse on the other end of that tablet. And that virtual nurse is really specifically working on education, teaching the patient about their medications, maybe telling them about their blood work that they just had and the results, maybe talking to them about their discharge plan, maybe talking to them about a rehab, scenario. They have to go to rehab. Why do they have to go to rehab? And explaining that to them. So taking a lot of that education that the floor nurse is spending with that patient, and then giving that over to a virtual nurse to free up the floor nurse to be able to spend more time on those acute needs on the floor. So, you know, seeing some really good results initially. This is sort of a newer program we're seeing out in the healthcare system this year, but it's a really interesting use case. And we've been seeing them using those tablets in the emergency room, for instance, to help the admission process, to do some of that H&P and medication entry. We're seeing them using it as a second witness for blood, for hanging blood and things like that. So people are getting super creative on using these products to help specifically solve the problem of staffing, which I'm sure you're all seeing. The second use case here is post-acute care. We actually have a webinar in 2 days with the University of Michigan and Dr. Toma. He'll be presenting his post-acute care programs. He has 3 of them outside of the hospital, and he's using remote patient monitoring to do that, and he's seeing great results, and he'll be kind of letting the world know about those results in a couple of days. So if you're interested, you can hop onto our website at healthrecoverysolutions.com, and you can register for that webinar in a couple of days. But the post-acute care cases, of course, you're all talking about and hearing the hospital at home programs, either non-waiver based or waiver based. We have multiple dozens of hospital at home programs that we're supplying equipment to. Of course, the home health and hospice space, the palliative care space, and then SNF at home. We have seen a couple of programs utilizing the equipment for SNF at home as well. Chronic care management, again, physician practice management. We see a lot of this. There is direct reimbursement with those CPT codes for RPM and chronic care management in this particular instance. We see this here in transitions of care, and again, chronic care management. And lastly, post-op surgery. We're seeing some use in pre and post bariatric surgery. So to Jennifer's earlier example for the weight loss, we're seeing this program being used for weight loss education and tracking and post-op complication, and making sure that we intervene timely for those patients so they don't go back to the ED. Complete joint replacement, we're seeing it used in those bundles to keep patients home and make sure that we're, you know, warding off infection and we're treating them at the right time, getting them the right care. And then CABG, lastly, cardiothoracic surgeries, we're seeing this as well in that space too. Okay. Lastly, we just have a screen here on what the research is saying for various different disease states. And you guys will get a copy of this slide deck so that you can certainly read this on your own. And then also maybe a little bit more detail on the products here at the end of the slide deck as well if you're interested. And of course, if you are interested, anyone can reach out to me and we can, you know, give you guys a demo or have any more further conversations about any questions that you might have. That's all we have if anyone has any questions.
I just want to add one other thing is that when we had some really rural doctors come back from Doctors Without Borders, we issued our telehealth equipment to them because they were initially isolated due to COVID, but they still had patient appointments. So they would put the telehealth equipment in a room and the patient would come in, take their own vital signs, and then they would have a video conversation with that doctor right at the doctor's office, but the doctor was maybe not right there. So
Thank you so much. We did get one question in regarding accessibility of the devices and the website and apps. The question asks, would you talk about how you are ensuring mobile devices, medical devices, and or website apps are accessible to all patients who might opt into RPM? If a patient needs a talking thermometer or an accessible glucose monitor, for example, what does the process of getting those look like on an individual basis?
well, the equipment does talk to them, and it will give them medication reminders and things like that. So the equipment already talks out loud, and it'll alarm and say it's time for to obtain your weight. And we set those alarms up based on what the patient wants. The talking glucose monitor, it'll read it out loud off of the tablet, because it'll say your weight was such and such and your blood pressure is this, and then so it reads it out loud to them.
Yeah, and we do have 15 different languages built into the tablet. So if there is a language barrier, we can help with that too.
Awesome. Thank you. If there are any other questions, feel free to pop those into the Q&A or the chat boxes. And then while we wait to see if anything does come in, I'm just going to take over presenter mode and share our agenda with a couple of updates we wanted to make sure everyone was aware of. I said this out a couple of times, but AHI's Adirondack Rural Health Network program did collaborate with our North Country Telehealth Partnership to create 2 new telehealth billing and coding webinars. These were presented by the team over at Northeast Telehealth Resource Center. I have the links here, and I'll make sure that those are sent out in the notes as well. One is just, overarching telehealth billing and coding beyond the basics, also includes some SDOH information, which is really great. And there's a second that is more specific to billing and coding for our FQHC and RHC partners, because we know there are some nuanced billing regs for that. So those 2 are available on our website and on YouTube. So I'll make sure everyone has that link if interested. There's a second update from our partners over at the Northeast Telehealth Resource Center. They have created a new training video focused on effective physical exams via telehealth. It's a really great video that really demonstrates best practices for physical exams via telehealth, including tips and tricks, using at-home devices, best practices for working with an interpreter, which is great for that accessibility. Different ENT and head and eye exams, respiratory, cardiovascular, abdominal, neurological, so many more. It's a really great video. I implore you all to take a look at that if it's applicable. And again, I'll send that link out to you all. I mentioned this earlier with our DOH updates, but the New York State offices of DOH, in collaboration with OHIP, OASIS, OMH, OCFS, and OPWDD have created the Telehealth Consumer Survey to get some more information on all things telehealth from the consumer point of view. Sent it out back in May, but there are now some flyers created to share in your offices to get your patients or community members to take the survey. I think that the closing date for the survey was also extended. Now it's closing on August 1st. And this will really help to inform policy development and implementation within the state. So we encourage everyone to share that widely with your partners. It's now available in 11 languages as well, which is awesome. There's another great resource available supporting telehealth care delivery created by the Greater New York Hospital Association. It's a guide to help with the skills and education to support virtual, telephonic, and digital care. So I have included that as well with the notes. I sent this out back in June as well, but HHS did issue guidance on audio-only telehealth and HIPAA guidelines. So again, that will be included as well. A couple upcoming events of note. There's a couple metric webinars, telehealth during and after the pandemic. There's an ATA roundtable discussion on the role of telehealth for excellent healthcare in rural areas, which I will definitely be checking out. And a couple more from NETRICS or the National Telehealth Resource Centers, including artificial intelligence and applications for virtual care, as well as implementing telemed in public libraries, insights from early adopters. Finally, wanted to remind everyone to save the date for our North Country Leadership Summit, which is the collaboration between our AHI Leadership Summit and the North Country Telehealth Conference. Again, like last year, it's being held virtually on the week of September 19th. We'll have a full week of telehealth and population health presentations. And we also have our Telehealth Innovator Award nominations open. I have that up here. I implore everyone to nominate any of your colleagues or staff that you would consider telehealth innovators. If you serve the North Country and create or deploy telehealth projects for hard to reach populations using innovative models for technology for home care delivery or healthcare, and other, criteria. And here I have that linked as well. Please feel free to send in your nominations, and we will be highlighting our telehealth innovators during that conference, September the 21st, which is the Wednesday of that. So I think that was my final update. So I'll go ahead and stop sharing. Just make sure I'm not missing anything in the chat or the Q&A. I don't think there are any questions for our presenters. Like always, I will be sending out the notes and the recording of the presentation to all of you and our partners. And I'll also include the slide deck that Jenna had shared. And I'll include Jenna, Jennifer, and Sarah's contact information in case you have any follow-up questions. And with that, I want to thank you all for joining us today. Again, save the date for our conference. And if you have any questions on all things telehealth, feel free to send that our way. And again, have a great day, and we'll see you next time.
Thank you so much.
Thank you, everyone.